You wouldn't hire a plumber to fix a broken pipe. Watch them swap out the metal and then expect that pipe to dynamically change its own shape every time your hormones fluctuate.
Right, right, exactly. I mean, the marketing materials out there really love to imply this simple binary, like you're broken and then you're fixed.
Yeah, but when we look at the billion-dollar industry of vaginal rejuvenation, people are often sold these quick, mechanical plumbing fixes for what is actually a living, constantly shifting biological landscape.
They really gloss over the reality that this specific tissue is just relentlessly influenced by aging, by estrogen levels, and of course, major physical traumas like childbirth. It is a biological moving target.
Which is exactly why we are jumping straight into this massive stack of sources for you today. We've got clinic guides, medical journals, NHS documents, and statements from major medical bodies like the FDA and ACOG.
It's a lot of material.
It is. And our mission for this deep dive is to map out the actual timelines and realities of these procedures. We want to decode how long these results really last, the intense physiological reality of the recovery periods, and the critical sequencing of treatments.
Right. The sequencing is huge.
Yeah, specifically, we want to figure out a question that comes up constantly for you listening. How long should you actually wait between different life events, non-surgical treatments, and actual reconstructive surgery?
Because navigating this menu of options really requires a deep understanding of how human tissue heals on a cellular level. You cannot rush biological cycles, no matter how much a glossy med-spa brochure, promises an overnight transformation.
So let's start with the options that promise the absolute fastest turnaround and shortest recovery, because this is what's just exploding on social media right now. The energy-based devices. The non-surgical fast track.
Right. So when we talk about energy-based devices in this field, we are primarily looking at two distinct methods. Lasers, specifically fractional CO2, and erbium-YA lasers, and radiofrequency, or RF devices.
And the sources say these procedures are lightning fast, like 5 to 8 minutes in an outpatient setting with no general anesthesia, just a topical numbing cream.
That's right.
But I mean, I understand they deliver heat, but how does blasting sensitive tissue with a laser actually rejuvenate anything?
Well, the core mechanism of action relies on controlled thermal injury. So let's look at the fractional CO2 laser, for example.
Okay.
The laser beam is fractionated, which basically means it's broken up into dozens of tiny microscopic beams. It targets the water inside the cells of the vaginal epithelium.
I see.
Yeah, and the energy instantly heats that water to the boiling point, literally vaporizing the cell and creating a microscopic column of thermal damage.
Wow, vaporizing.
It sounds intense, I know, but because it's fractional, it leaves bridges of perfectly healthy, untouched tissue right in between those microscopic wounds.
Okay, so looking at how this targets the epithelium, it's essentially the biological equivalent of aerating a lawn.
Yes. That's a great analogy.
Right, like if you have a patch of grass that's compacted and struggling, you take a machine and punch thousands of tiny holes into the dirt. It looks a bit violent on the surface, but it allows air and water and nutrients to get into the soil so the grass can grow back thicker.
The body's response is incredibly similar to that. Those tiny columns of vaporized tissue, they trigger a massive, localized wound healing cascade. First, you get the inflammatory response where blood rushes to the area.
Right.
Then the proliferation phase begins. The body starts producing these specialized cells called fibroblasts. And these fibroblasts are like the factories that churn out new structural proteins.
So they're building new, tighter collagen and elastin fibers.
Exactly.
And the sources also mention neoangiogenesis.
Right, which is just the creation of brand new blood vessels. So by forcing the tissue to rebuild itself, you are restoring blood flow, which in turn restores tissue thickness and natural lubrication.
But here is where I get a bit tripped up on the timeline, though. The clinical guidelines are very strict that a patient needs 1 to 4 sessions, but they must be spaced 4 to 6 weeks apart.
Yes, that's a hard rule.
So if I'm looking at this as a consumer and I'm just getting tiny laser pricks, why can't I go back every week? Like, if I want this done fast before a vacation, why not speed up the collagen growth by hitting it harder?
Because if you hit the tissue with another laser treatment before it has finished the remodeling phase from the first one, you aren't compounding the benefits. You're just compounding the trauma.
Oh, wow.
Yeah, you're throwing more inflammation onto tissue that is desperately trying to synthesize new collagen. You have to give the tissue that full 4 to 6 weeks to move completely out of the inflammatory phase and into the maturation phase. Otherwise, you risk severe scarring.
So you are totally bound by the biological speed limit of your own cells. And during that 4 to 6 week wait, The initial physical recovery seems deceivingly quick. I mean, clinic guidelines say you can resume daily activities in 24 to 48 hours, but then there are the restrictions. No sexual intercourse, no tampons, and no direct heat-like hot showers, baths, or saunas for 3 to 7 days.
Right, because you have open, albeit microscopic, wounds in a mucosal environment. Exposing that to a hot sauna, for example, just exacerbates the internal inflammation and swelling.
Makes sense.
And introducing friction or foreign objects before the epithelium has sealed over those microscopic columns, that introduces an incredibly high risk of localized infection.
And after all that biological remodeling, these results really only last about 9 to 18 months. You have to go back to annual maintenance touch-ups.
You do.
So if we are essentially injuring the vaginal tissue every 4 to 6 weeks for a few months, and then returning every year to purposely injure it again to keep it youthful, is that actually safe over the span of a decade?
Well, the long-term safety profile is actually the absolute center of a fierce debate in the medical community right now.
Because the regulatory pushback is intense. In 2018, the FDA issued a major safety communication explicitly warning against using these energy-based devices for vaginal, quote, rejuvenation.
Right. We really need to look closely at what the regulatory bodies found there. The FDA cited serious adverse events associated with these devices when they're used electively for cosmetic tightening.
Like what kind of events?
The reports included severe vaginal burns, significant irreversible scarring, and chronic pain.
Wait, severe burns and chronic pain in that specific area? That sounds horrific.
Yeah.
Especially given that this is marketed by med spas as a quick, lunch break confidence boost.
The gravity of those complications really cannot be overstated. Major medical bodies, including the American College of Obstetricians and Gynecologists, or ACOG, and the Royal College of Obstetricians and Gynecologists in the UK, have drawn a very firm line here.
Yeah, they state that these procedures lack robust, long-term evidence for cosmetic claims, and they are officially categorized as not medically indicated outside of controlled clinical trials.
Exactly.
But the sources also present this massive medical flip side. Despite the FDA warnings regarding cosmetic use, there is a mountain of clinical trial data showing that these exact same lasers are highly beneficial, even vital, for a specific severe medical condition, genitourinary syndrome of menopause, or GSM.
Right, so GSM is a chronic progressive condition caused by a systemic drop in estrogen. To understand why it's so devastating, you have to look at what estrogen actually does for this tissue.
Okay.
Estrogen is responsible for keeping the vaginal epithelium thick and elastic. It also causes the cells to produce glycogen. And good bacteria in the vagina, called lactobacilli, feed on that glycogen and produce lactic acid.
Which keeps the vaginal pH acidic and wards off infections, right?
Exactly.
So when estrogen drops during menopause, that whole ecosystem essentially collapses.
It does. The tissue physically atrophies. It becomes paper-thin, very fragile, and it loses its blood supply. The pH becomes more alkaline, leading to recurrent urinary tract and vaginal infections. And the resulting symptoms are severe vulvovaginal dryness, chronic burning, and dyspareunia, which is intensely painful intercourse.
And the standard treatment for that is usually localized estrogen therapy, right? Like a cream or a ring. But this is where the data really pivots. What happens when a patient absolutely cannot take estrogen?
This is a huge point. For women who are breast cancer survivors, their cancers are often hormone receptor positive. So introducing estrogen, even a localized topical cream, can be strictly contraindicated by their oncologist.
Wow.
For these women, GSM can absolutely destroy their quality of life. They have debilitating pain and very, very few treatment options. So in these highly specific clinical cases, the controlled thermal injury of a fractional CO2 laser offers a non-hormonal way to force the body to restore that tissue thickness and blood flow.
I just have to pause here because the gap in intent is staggering to me.
It really is.
On one side, you have a med spa blasting healthy tissue in a 30-year-old for a cosmetic tightening effect, risking permanent scarring that the FDA is waving massive red flags at. And on the other side, you have gynecologic oncologists using the exact same machine to treat severe, debilitating tissue atrophy in a 60-year-old breast cancer survivor.
Because the context of the tissue's baseline health dictates the risk-to-reward ratio. If a patient is suffering from severe atrophy, the regenerative benefits of the laser vastly outweigh the risks of thermal injury. The intent fundamentally changes how we evaluate the utility of the device.
So if lasers and radiofrequency are temporary, controversial for purely cosmetic use and really only address the surface-level mucosal tissue. What happens when the actual structural muscle is damaged? I mean, you can't laser a separated pelvic floor muscle back together. There has to be a structural intervention.
Right. When the issue moves beyond the surface mucosa and into the underlying musculature, which is very often due to the trauma of childbirth, we move entirely away from lasers and look at surgical reconstruction, vaginoplasty and labiaplasty.
So labiaplasty reshapes the external tissue, while a vaginoplasty is the internal tightening of the vaginal canal. According to the surgical guides, a vaginoplasty involves repairing separated pelvic floor muscles, specifically the levator ani muscles, and removing excess stretched vaginal lining.
And the recovery timeline for this surgery is just a completely different universe compared to a 5-minute laser session.
Let's look at the physiological stakes of this recovery, because the sources describe it as grueling. You are under general anesthesia for 1 to 2 hours. For the first 24 to 48 hours, you are on strict bed rest. And a major focal point in the post-op guides is extreme, meticulous care with bowel movements. They prescribe heavy stool softeners, and they emphasize that you must use them.
The internal mechanics of the repair make this critical. The surgeon has pulled the separated pelvic floor muscles back together and secured them with deep, absorbable sutures. Those stitches are the absolute only thing holding the structural integrity of the repair while the muscle fibers slowly knit themselves back together.
Wait, so if a patient strains during a bathroom trip on day 2?
They can literally blow out the entire pelvic floor repair.
Oh my gosh, that is terrifying.
It is. The internal pressure of straining can snap those sutures, completely reversing the surgery and causing a severe internal bleeding.
Wow. And even as you move into weeks 1 through 3, you're dealing with immense swelling and bruising, simply because of gravity. You can return to a desk job, but there is absolutely no heavy lifting and no squatting, again, to protect those internal sutures.
Then you enter the critical waiting period of weeks 4 through 8. The clinical mandate is absolute pelvic rest. No sexual intercourse, no use of tampons, nothing introduced into the canal for a minimum of 6 to 8 weeks.
Right.
The mucosal tissue on the surface might look healed, but the underlying muscles are still highly vulnerable to shear force or friction.
And here is the part that really surprised me. Even when a patient is cleared for normal activity at week 8, they are nowhere near the finish line. The sources note that while the structural physical results settle around month 3, nerve regeneration can take up to a full 12 months.
Yeah, nerve fibers, specifically the axons, grow back incredibly slowly, roughly 1 millimeter per day under ideal conditions. During a vaginoplasty, sensory nerves are inevitably cut when the excess tissue is removed.
Right.
So it takes a full year for those nerves to find their pathways, regenerate their myelin sheaths, and for full sensation to return to the area. It requires immense patience.
But the trade-off for this grueling, year-long recovery process is that, unlike the lasers that fade after 12 months, the structural results of a surgical vaginoplasty are permanent. Well, permanent with one major bulldozer-sized caveat.
Childbirth.
Exactly. I was reading the surgical warnings and it clicked. A vaginoplasty is like doing a full, expensive foundation repair on a house. You are fixing the deep structural joists. But if you have a vaginal delivery after you've recovered from the surgery, you are basically driving a bulldozer straight through that brand new foundation.
That is a perfect way to describe it. The levator ani muscles that the surgeon just painstakingly stitched together will be forcibly stretched beyond their capacity and likely torn again as the baby passes through the birth canal. It demolishes the surgical repair.
Which brings us to the core focus we really wanted to unravel for you today: sequencing and timing. Because childbirth acts as a biological bulldozer and because surgical recovery is so delicate and intense, the timing of when you get these procedures is paramount. So let's answer that big question. How long should you wait between different life events, non-surgical treatments, and surgery?
Let's tackle the childbirth timeline first. The clinical consensus is that you must wait at least 3 to 6 months postpartum before even considering a consultation for vaginal surgery.
Okay.
The pregnancy hormones need to leave your system, the immense vascular swelling needs to subside, and the tissues must naturally settle. A surgeon needs to see your true baseline anatomy, not your postpartum anatomy.
But the overriding medical recommendation across the board is simply do not undergo a vaginoplasty until you are 100% certain you are done having children.
Precisely. Now, let's look at how non-surgical and surgical treatments interact with each other. Because what if a patient has already had a surgical repair, perhaps a vaginoplasty, a prolapse repair, or pelvic mesh implanted. And then years later, they want to go to a med spa for a quick radiofrequency session.
This seems like a massive hidden danger in the sources. If you have had pelvic mesh implanted or a previous deep structural repair, your anatomy is fundamentally altered. You have internal scar tissue, and scar tissue doesn't conduct heat or energy the same way normal mucosal tissue does.
Exactly. And a standard med spa clinician might not realize that the radiofrequency energy could heat up the internal synthetic mesh, or that the internal scarring changes the depth of the thermal injury. It can cause horrific complications, including eroding the mesh through the vaginal wall. The absolute safest sequence is that you cannot let anyone use an energy-based device near a previous surgical site without having a highly specialized urogynecologist review your surgical records first.
Okay, so massive warning sign there. Do not put lasers over old surgical mesh without a specialist. But let's look at a safer sequence. Say you had a straightforward vaginoplasty. You wait until you were done having kids, you survive the 8-week recovery, your muscles are permanently tightened, and your foundation is solid.
Right.
But 10 years later, you hit menopause, the estrogen drops, and the surface tissue starts to thin out and dry up, leading to that GSM condition we talked about. How long do you have to wait after surgery before you can use a laser?
Well, you must wait until the surgical tissue has completely finished its remodeling phase, which means waiting at least 3 to 6 months post-op before applying any thermal energy. But once you are fully healed, surgeons actually often recommend using lasers or RF as ongoing maintenance.
Right, because the surgery fixed the muscle, but it doesn't stop natural cellular aging. The foundation is strong, but the paint on the walls is peeling.
Exactly. So utilizing non-surgical lasers decades after a structural surgery, just to maintain surface hydration and elasticity, is a very common, very effective sequence.
And what if we reverse it? Like, you've been getting laser treatments, but you decide you want the permanent surgical fix. How long do you wait then?
You must wait for the inflammatory phase of the laser to completely subside. A surgeon will not want to operate on swollen, highly vascularized, inflamed tissue. You need a washout period of at least 4 to 6 weeks after your last laser session before undergoing a vaginoplasty.
So, synthesizing all of this for you listening, it really comes down to respecting the biological speed limits of your own body. If you are pursuing non-surgical collagen boosts, you are committing to a strict 4 to 6 week waiting period between sessions to avoid compounding trauma.
Right.
If you are looking at surgical structural repairs, you are committing to months of internal healing, protecting fragile sutures, and waiting a full year for nerves to regenerate. And you have to sequence all of this carefully around childbirth and menopause.
It demands patience, frankly, and a real refusal to fall for marketing that promises instantaneous results.
Which actually leads me to a final, really provocative thought from the clinical literature. It completely flips this entire conversation on its head. We have spent this entire deep dive talking about rejuvenation, tightening, restoring, and maintaining the anatomy of youth, which is primarily focused on facilitating penetrative sex.
But the sources detail an entirely different surgical alternative for older, postmenopausal women who suffer from severe pelvic organ prolapse, which is where the bladder or uterus is physically falling into the vaginal canal, and who have decided they no longer desire penetrative sex. It's called vaginal closure surgery, or a colpectomy.
I was reading this, and it is a profound paradigm shift. Instead of subjecting a patient to repeated, lifelong laser maintenance or highly invasive, difficult reconstructive surgeries that have a high failure rate just to preserve an open vaginal canal, the surgeon simply closes the vaginal space entirely to act as a structural hammock, supporting the pelvic organs.
And it is incredibly effective. It completely abandons the pursuit of youthful anatomy and prioritizes immediate symptom relief and quality of life.
It asks a totally different question. What if the ultimate solution for some isn't about enduring lasers and reconstructive recoveries to turn back the clock? What if it's about surgically adapting the body to comfortably fit an entirely new stage of life and entirely new personal desires?
It forces us to remember that medical interventions should ultimately serve the patient's lived reality, not an idealized standard of how the anatomy is supposed to look or function.
So as you think about the plumbing or the foundation of that house, remember that you don't always have to rebuild it exactly the way it was originally constructed. Sometimes, the best, healthiest way forward is to redesign the floor plan altogether. Something for you to mull over. Catch you on the next deep dive.